Prof Shingai, if a man has been diagnosed with prostate cancer and does need active treatment, what are some of those treatment options that are available to a man? And should a man get a second opinion? What is one treatment necessarily better than another treatment?
Okay. The short answer here is that I think the important thing that most of us physicians are doing now is that we have what we call MDTs, or multidisciplinary teams. That would include doctors in, for example, if it's a urologist for prostate cancer, we'd also have an oncologist there, be it the radiation oncologist, and we'll also be looking at social workers so we have a informed discussion with the patient about the way forward and what our plans are. If we decide that as a team that the patient needs to have some treatment, any patient is, of course, can have a second opinion. It's the right of any patient to do that. But generally, if you have an MDT, most of the patients will be quite comfortable after we've had a discussion. The active treatments that we usually find will depend a lot on different factors for the cancer. If it's a nasty cancer, when we look under the microscope, if it's spread around the area, if it's gone to the bones, or what's happening. What we really want to do is pick up the cancers before they've spread. And if we pick it up early, then we usually will do one of three things, depending on how healthy the patient is. Number one is what we call radiation treatments, which are basically we either put radiation seeds into the prostate, which is called brachytherapy, or do what's called external beam radiation, where we use what we call a linear accelerator, which is like a big X-ray machine to focus radiation onto the cancer, kills the cancer. If your cancer has been picked up early, you probably have about a 95% chance of cure. The second option is to do what we call radical prostatectomy. And what we do then is we do the surgery where we open up and remove the whole of the prostate cancer. Again, if it's picked up early, your chances of success are about 95% again. The third option, and this depends a lot on what type of cancer you have, but most people are going to have what we call low-risk cancers, which means that the blood test, the PSA, is relatively low, below 10, that the type of cancer, when we look under the microscope, is what we call a Gleason 6. It's a little bit complex, but we're now changing it to a risk stratification where it's going to be risk stratification 1. And the patient, when we do the examination, doesn't have spread around the cancer. If they satisfy these criteria, there's also the option of what we call active surveillance. Now, active surveillance is not no treatment, but what it means is that we follow the patient up without doing anything, no radiation, no removal of prostate. We just have to re-biopsy after a period of time. We monitor the blood test. We may be doing x-rays, like the particular one what we usually do now is something called an MRI, or magnetic resonance imaging, which can give us an idea if the cancer is going to be nasty. And about 50% of men in this group will not have to have any active treatment.